Next we have Dr. J.K. Reddy, who will be speaking on facing the possibility of intraocular lens power going wrong. I mean, you have a doubt that the IOL power calculation that you have done is wrong. So what to do in those cases, sir?
Thank you, Srini, and very good morning. You will be wondering why should have a doubt on the table when you are preoperatively prepared the patient for surgery. But it's not unusual for us. Many times we don't see the patient. Many of our patients we don't see. We see them on the table only. Some they will be posted and they will want surgery, and like that it goes in India. Many of our patients. So when you see it, all the workup will be done. They say it's a tori case, something like that. Then you look at the topography, you see a case of keratoconus or a corneal scar or a injury with a opacity where you cannot rely on the K reading for calculation of the IOL power. So many of the, so if we see pre-operatively, then it's okay. We look at the spectacle correction, what is the cylinder and what is the K reading, like that we try to see. But if you don't see the patient, you see them on the table, you see a case like this topography, then we cannot go ahead with a toric lens or IOL power, what is already calculated by the scan. So these are the some other cases where you see post-LASIK. Of course, now post-LASIK we have a lot of formulas, but sometimes they don't recognize. They send it, they do it, and on the table you see, when you see topography, you see is a post-LASIK case. So we have to recalculate and put it, and there is no time. Already you started surgery, then you look at the lens. It's a post-LASIK. So what to do in these cases? This is the big question. It's not unusual. Once in a while it happens for us. So what we do is, in these cases, we go ahead with a McCool technique, most of these cases. So when you see a case like that on the table, see a bizarre topography and IOL power, we don't go ahead with implantation. We just take that, we do cataract, we finish phacoemulsification and we send the patient to the ward. After 1 or 2 hours, they take a power correction, refractive correction. What is the spectacle correction? A good optometrist will do it into 1.75 for plus power. That's what we go with the formula. It works very well. You don't need to worry about effective lens position. It works reasonably well. So for example, this case, we had 8 diopters, 9 diopters of astigmatism. This is on the table. So we send the patient home, after surgery, we send the patient back, and the same thing, we do cataract extraction done, and patient left aphakic, and most of the time on the same day on the table, same day, after 2 hours, we do 1 to 2 hours, we do aphakic refraction, and we take the spherical equivalent into 1.75. Then we bring the patient and implant. If there is some striakeratitis or there is some problem, a little bit corneal edema and not able to get, then we do the next day. The next day we put on steroids and then glaucoma, oral acetazolamide, then next day or after 2 days also, sometimes we do that and we implant these cases with the IOL after. And these are the few cases example which I had in my records. For example, this patient had case 1 plus 11 diopters and spherical equivalent came 11.25. So we calculated and then we put a 11.25 into 1.75, 19 that means almost around 20 diopters implanted. And another case like this last case, this is okay. This is not a simple case. If you take the last case, the keratoconus case, plus 6 into plus 3.75 into 70 degrees. Actually, patient is having with the rule astigmatism topography, but he is accepting against the rule in 1. So these cases, we just go ahead and put a spherical equivalent, then we give the refractive correction, post-operatively some spectacle correction. So this is how they improve very nicely. If there is no problem, this technique is very nice. You don't need to worry about much of the surprises with this technique. So what you have to do, you have to just keep calm and need not worry. Just look for a solution and finish the case. Thank you very much.
Thank you, sir. Can we actually,
the table?
you have the
Yeah.
online calculators for post-refractive surgery cases.
Yes, now
You,
we are
you
having.
do you do it routinely, so to really confirm that whatever we have got in the post-refractive surgery cases on table to confirm, okay, this is it.
See, that's true. The problem is online calculator post-refractive surgery. If you have a very nice central ablation, it's all right. But 30 years back, the case is coming now. The machines are really not that great. So they have decentered ablations. So the Bezier power, they take spectacle correction. There is no relationship between the topography and spectacle correction. They will be completely different. So when you have a decentered ablation or a very small optical zone, 4 millimeters, 5 millimeters like that, McCool technique is the best. That gives the ultimate. It's not any hypothetical calculation. That's the refractive state is the ultimate one.
And do you have to really take the patient after
Yeah, I
2
actually,
hours
I do on table only.
On table.
On table you can do it, but on table is only refractive value. Refractive value is different from refractive correction. So on the table we used to do refractive. See, in decentered ablation, irregular cornea, you can't get any reading. You don't get any retinoscopic reflex. You don't get any AR. You don't get anything. When you have such a trauma with a central corneal scar, but they improve very nicely. Post-operatively, central scar, corneal scar, you do some refraction, they go up to 612.
So you look for the acceptance and then
Yes.
into 1.75 sort of. Okay, thank you, sir.
So, but the multiplication factor is the same for post-LASIK and the normal cases, or?
Any refraction same as far as it is a plus. If it is a minus, then into 1.5.
1.5.
If you are putting minus, then it's 1.4 or 1.5. If it's plus, it's 1.
The role of intraoperative aberrometers for such cases is something, but then
So
it
they
is a-
spend $1 million, $2 million, 200, 300
Yeah,
million
it's a
dollars, and the
sophisticated,
companies lost
yes.
around $500 million.
Yes,
So all
totally.
they become bankrupt.
Yes,
But ORA is on the same principle. ORA is being real-time aphakic refraction.
it's an aphakic refraction, and
Wave scan, that was closed down. 3 people purchased it, and all the machines are in the storeroom now. And
yes,
now
it's a
now
very
it's coming another
sophisticated
company.
device. Yeah.
They're good, but takes a long time to
No,
develop.
and again in post-LASIKs they have a limitation, they do not image well. Whenever there is a corneal haze and there is an interface, then the imagings also are not that accurate as you would get. And probably if you're looking at decentered ablations, irregular corneas here, and what's now said is the Kane formula works well, but I don't have an experience of having used Kane formulas for keratoconic cornea. So this is also akin to iatrogenic keratectasia. So that's something which we could probably look at, but I also do not have experience